Welcome back to part 6 of our advanced neurosurgery coding curriculum. We're moving away from the basic craniotomies today and getting right into the millimeter-specific, honestly kind of sci-fi level procedures that totally define modern neurosurgery. In this explainer, we're going to equip you with the exact clinical understanding you need to completely master the precision surgical toolkit. So let's just dive right in.
We'll be following the surgeon's exact workflow today. We'll start with brain GPS localization, then move right through stereotactic biopsies and thermal LIT treatments, detail the operating microscope rules, and finally wrap up with a precision coding masterclass.
Part 1. The Brain GPS System, Navigating Precision. You know, in modern neurosurgery, treating a deep cranial lesion safely means you simply cannot navigate the intricate pathways of the brain without an exact roadmap. And I mean having that roadmap before the very first incision is ever made.
Think about how you use the GPS on your phone. Just like a GPS navigates you to a precise street address rather than just pointing you to a general city, stereotactic computer-assisted navigation guides surgical instruments flawlessly to the exact coordinates of an intracranial defect. I mean, it's not enough for a neurosurgeon to just know a tumor is somewhere in the frontal lobe, right? They need the exact X, Y, and Z coordinates to reach that pathology while entirely avoiding the critical functional areas of the surrounding brain tissue.
Now, when it comes time to actually code for this incredible navigation, your critical clinical distinction lies right at the duramater. That's the tough, outermost protective covering of the brain. You're going to report the intradural add-on code 61781 when the dura is deliberately opened to expose the brain tissue. This allows the surgeon to navigate directly inside the brain matter itself. On the flip side, you report the extradural code 61782 for navigational work that is isolated strictly outside the dural covering. A perfect example of this would be complex cranial base bone work or navigating through sinus corridors where the dura remains completely intact.
What's really interesting about these codes is how they interact with one another. Because these are highly specific add-on codes representing a singular, dedicated navigational approach for a specific anatomical zone, a single surgeon absolutely cannot report both the intradural and extradural variations during the exact same operative session. They're mutually exclusive. So you always have to check your primary procedure first to ensure navigation isn't already bundled. And if it isn't, well, selecting between the intradural and extradural environment is your defining step.
Section 2. Stereotactic brain biopsies. Planning versus real-time. Okay, now that we're securely mapped out, the surgeon has to precisely extract.
This demands a much more sophisticated approach than your standard traditional burr-hole biopsy. By pairing advanced three-dimensional spatial mapping with incredibly precise instrument insertion, stereotactic biopsies ensure the tissue aspirated or excised is extracted exactly from the targeted lesion. This guarantees that the surgeon isn't just blindly probing around, they're extracting the exact cells needed for pathology. To give you an idea of the clinical magnitude here, we're literally talking about accuracy down to a single millimeter, which ensures healthy neural tissue is left completely untouched.
So what does this mean for us? Well, the crucial point for your coding choice here hinges entirely on the timing of the imaging guidance. You'll assign code 61750 if the CT or MRI scans were utilized strictly for planning only. That means the stereotactic coordinates were calculated before the surgery even began, and no live imaging was used during the actual extraction. But you've got to upgrade to code 61751 if the surgeon actively utilized live, real-time CT or MRI scanning right inside the operating room to dynamically guide their instruments during the procedure.
Moving on to Section 3. Laser interstitial thermal therapy, or LITT for short. But what happens when the goal is actually actively treating these deep, complex tumors, rather than just biopsying them?
For this, neurosurgeons can deploy a highly targeted, minimally invasive heat treatment. The clinical mechanism here is truly fascinating. It involves advancing a very thin laser catheter directly into the deep brain lesion. Once it's perfectly positioned, the laser is activated to thermally coagulate, basically cooking the tumor cells. Crucially, this entire process is continuously guided via MRI thermometry. That lets the surgeon watch a real-time heat map of the brain, ensuring the thermal energy destroys the tumor margins while absolutely protecting the adjacent, healthy brain tissue from heat damage.
Accurate coding for LITT requires you to identify the complexity of the surgical approach directly from the operative report. You're going to select code 61736 for a single brain lesion targeted via a single trajectory. However, if you're reading an OP report for a really complex case, maybe a large, irregularly shaped tumor or multiple distinct lesions demanding multiple surgical trajectories and multiple laser placements, then you'll report code 61737.
All right, Section 4, the operating microscope rules. Let's talk about visualization and see how this all builds together. Because honestly, none of these delicate micro-interventions are even possible without superior illuminated visualization of those incredibly intricate neural structures.
Listen closely to this part, because the overarching requirement for reporting the operating microscope is the explicit documentation of microsurgical technique. It's just not enough for the microscope to simply be in the room or used for general macroscopic visualization. The operative report has to clearly detail that the surgeon utilized the microscope to perform precise cutting, suturing, or delicate dissection of neural, vascular, or tumor tissue.
The specific add-on code for this microsurgical technique is 69990. And a really vital compliance rule to remember here is that this add-on code is billed only once per operative session when properly documented. It absolutely does not matter how many times the surgeon adjusts, cleans, or even curses at the microscopic lens during the surgery. It remains a single, encompassing unit of precise visualization for the entire operative encounter.
Finally, Section 5, Precision Coding Masterclass. To prevent claim denials and ensure absolute compliance, clinical audit teams really have to bridge the gap between the physical surgical suite and the coding ledger. So let's bring everything we've talked about all together.
By systematically extracting the primary surgical procedure first, you set your foundation. From there, you carefully layer on the exact procedural details. Isolate the dura barrier to determine your intradural versus extradural navigation. Verify the exact timing of the imaging to correctly code a stereotactic biopsy. Count the precise number of probe trajectories to lock in your LITT codes. And finally, confirm the explicit documentation of microdissection before adding the operating microscope. This kind of systematic approach ensures you capture the complete, accurate clinical picture every single time.
So I'll leave you with this question for your own practice. Are you capturing every single level of surgical precision without triggering a denial? Keep refining your anatomical reasoning, always double-check those add-on exclusions, and decode healthcare with Harshal.